Assalamualaikum warahmatullahi wabarakatuh, and a very good day to everyone. I'm Dr. Rozanizam Zakaria, psychiatrist from Kuliah Medicine IIUM. You are listening to my recorded lecture entitled Psychiatric Interview Techniques and History Taking. It is part of Introduction to Psychiatry course for Year 4 student, Medical Degree Programme IIUM Kuantan. However, I will also upload the same video to my YouTube channel, so in case everyone else is interested to get to know this topic or to revise about this particular topic, regardless of where you're from, you'll be able to join the discussion, inshallah. So for my students, I will just give an overview and highlights of the topics from this recording. The rest of the notes is available. I will share with you the slides in Google Classroom or other methods that will let you know later on. So this is the outline of the presentation. Essentially, we'll be talking about one, why does it matter? I really want you to understand and appreciate the importance of going through the right process, learning the right skill in order to become a good doctor by appreciating the arts of psychiatric clerking. It may specifically designed for psychiatric posting. However, I do believe that the essence of these tips and techniques is relevant wherever you're going to be practicing, as long as you know that your important part as a doctor is to get to know your patient before treating them. Second part of the presentation is about what it is and how it's going to be done, the content of it, what needs to be covered under psychiatric clerking, and last but not least, we'll be covering about challenges that you face either from exam setting or from when you are dealing directly with patient in clinical context. And towards the end, as a bonus for all of you, I'm going to give some homework in order for you to have a look and relate back to what I have discussed during this topic. If you think you have mastered the topics and you have no problem with psychiatric clerking, you can skip the rest of the lecture and go straight to the homework. But if you are not confident enough, then you go through this topic one by one, inshallah. So if you notice that during the first slide I included a quote. Imagine if lab and radiology department were closed down for good. So how do you think you're going to deal with your patient? So think about this question and do not consider yourself as a doctor in psychiatry department. Wherever you'll be working, imagine that you come across a situation where you have no other options other than to go back to a very fundamental and primitive way of diagnosing patient, which is going back to patients and listen carefully at every words and experience that they have gone through, in order for you to make up your mind in terms of what essentially the diagnosis that this patient has. And remember, whatever diagnosis that you have will determine the treatment that you give to the patient. Wrong diagnosis, wrong treatment. Simple as that. Fortunately enough, and most part of medicine these days, we have ample opportunity to use all sort of investigation. You don't have to worry about misdiagnose somebody with COVID-19, for example. We have tests to do so. You don't have to worry about having to test somebody's urine in order to understand in order to ensure whether they have diabetes or not, because we have blood glucometer or glucometer in order to assess their blood sugar level. But unfortunately, or for psychiatrists I would say it's unfortunately, we don't have such things in psychiatry, which basically means you are left with no option other than to look back at every single thing that the patient described to you, the family described to you, and what you can see from your mental state assessment in order for you to make up your diagnosis. Now, for somebody who wants things to be done rather quickly and want quick answer for everything, you might find this is terribly exhausting process. But to me, of course I'm biased as a psychiatrist, but I think this is the beauty of medicine. you are left to explore uncharted territory in every single patient that you see, in order for you to explore things and find out where things are. It's almost like um, a journey in a territory that you have never been before, and you know that towards the end of the journey you need to come up with something that is going to be very significant or important in someone's life. So um, it's not about what's not there, what's not available, but it's about working with things that are available. And of course, history is always readily available in every single patient. So that's why we need to appreciate the reason why psychiatric clerking is highly important thing. Now, when we talk about psychiatry, at the end of the day, there are three essential things that you have to understand. The pillars of psychiatry. Number one is the sign and symptom, or in psychiatry we call it psychopathology and mental state examination finding. So this is your raw material. This is your raw ingredients. So based on this, you work out through your history taking and interview techniques in order for you to get to the next pillars of psychiatry, which is the diagnosis and formulation. So diagnosis is the name and label that you give to the illness that the patient has, and formulation is the specific context of the diagnosis. So diagnosis can be something like major depressive disorder, but formulation explain why this person has major depressive disorder, how does it affect patient life, how does it present, and in what way does it different from any other major depressive disorder that you know of. So that's formulation. And the only way to get to the correct diagnosis and a proper formulation is through history taking, understanding problem list, and formulate the case. So this is the second task in psychiatric clerking. And of course, from there, your next task will be much easier, which is the management part. And of course, the management in psychiatry will be highlighting about biopsychosocial and spiritual approach. Therefore, you need to include relevant investigation that tailor that will narrow down your options of diagnosis and come up with a proper problem list and eventually a tailored treatment. So these are the three things that you need to know. So during discussion, we'll discuss further about this. With the case presentation that you'll be giving, you will put this into practice. But this is the basic concept of psychiatry. Now, why psychiatry interview is so different? Why do you have to bother about focusing on history taking and interview techniques and whatnot? So these are some of the ideas that I've thrown here for you to think about. Some of it I've highlighted. For example, unlike somebody who's come with a broken hip or a fever or toothache, the story is readily accessible. They will not hide anything, and they will describe every single thing that they've experienced in a simple term, in a clear-cut way. But it is not as straightforward as other part of medicine in psychiatry, whereby you have two issues. One is patient might not have insight, and second, patient might not realize that what they experience essentially is as symptoms of a specific mental illness. So the way you uncover the problem that they have will ensure that you get enough information. I give you a simple example. Somebody who experienced manic symptoms in bipolar disorder, for example. So many patients do not necessarily have the good insight. So they might not know that reduced mood for sleep, increase in energy, increase in self-esteem, pressured speech, increase in ideas are symptoms. So they might not readily come to hospital or explain to you this is what they experience. So you need to uncover it indirectly through questionings that you ask patients. So this is the beauty of psychiatry that you have to appreciate, that you will appreciate, inshallah, once you come across a patient with a psychiatric problem. And when we talk about psychiatry in people, of course, I'm not just talking about what to ask. It's also about how do you ask it. Okay? Because knowing what to ask might not necessarily help you to get where you want. Knowing how to ask is also another thing that is important. For example, a classical example about substance history, for example, it is very important in order to diagnose. It will differentiate from schizophrenia from substance-induced psychosis, for example. But knowing how to ask, knowing what to ask in substance history might not get you to the bottom of the problem. You have to know how to get to the stage where patient will open up and share with you every single thing that they experience with regards to substance use. So we'll talk about this in later slide, but just to highlight to you why is it important to learn how to maneuver your history in psychiatry. Alright, and hopefully by learning all these skills, at the end of the day, the aim is to have an effective interview. That is, to sit with the patient for 45 minutes to 1 hour, not just for the sake of sitting with the patient, but if you're given a situation, for example, in long case examination, your 45 minutes will eventually get you to the stage where you are able to get enough history to come up with provisional diagnosis, differential diagnosis, formulate the case, and offer your treatment and management for the patient. So it is important to get to that stage. So apart from that, your role is not only about diagnosis and managing the patient. In between this process, what is also important in psychiatry is to gain trust from the patient. Why trust is important? Trust is almost like currency with regards to psychiatry, patients and doctor relationship. No trust, no business. So as simple as that. For example, you're dealing with somebody who has personality issues, past history of trauma, recurrent episode of self-harm. So these are issues that can never be solved within 1 or 2 consultations. You need to have a stable relationship with the patient in order to get to the bottom of the problem and help patient to sort out their life issues. So trust is the glue that will hold together the whole management. And another thing that is important is not only about managing the patient, but it is also about being therapeutic for patient. If you are doing other surgical posting, for example, no matter how good you are with the theory, you will not be allowed to perform surgery on patient. You might assist, you might touch here and there. If you're lucky, you might be able to hold a needle for suturing or hold the tumor once it's been operated. But in psychiatry, you have access to patients' emotions while interviewing patients. Maybe even the doctors are not there to support or to be with you. But your relationship with the patient that you had during that 1 hour also might still be something that can be therapeutic for the patient. And another important aspect that I want you to also understand is having a good history techniques isn't only about diagnosis and management for psychiatric cases, but it's about cutting your costs. It's about making sure that you are doing justice for the patient, being fair with the patient. You might end up over-investigating if you miss 1 or 2 questions that are relevant throughout, this and that. But if you fail to listen to your patient and you jump straight to investigation, you might end up doing every single thing in order to complete your satisfaction to find out what's wrong with the patient. At the end of the day, the ones that win the job is the machine, not you. And that's not what we want. We want to create. We want to create doctors, not robots. Okay. We've talked about good rapport. And let's talk about how to develop rapport. So a simple advice is be genuine and respectful to patient. You might not have opportunity to see patient just yet, but once you see patient, whatever you have in mind, the stigmatizing ideas that you had prior to coming to psychiatry, you have to wash it off. You have to face patient with genuine and respectful manner. So that's what we hope that you get. In fact, it's not only for psychiatric patients, any patient that you'll see in the hospital. So the warm welcome, the body language, the way you ask patient, and of course don't be judgmental or prejudice the species of patients concerned. So that's important. Do not buy the idea that this is how psychiatric clerking is done. So this is the wrong perception that India has given to psychiatry. I've never clerked my patient while they are in such position unless they are medically ill. So the process is similar to any other interview, any other clerking, but each step contains a different components that you need to highlight. So of course setting is similar to other parts of medicine. Plus you need to be careful about the risk of harming others or risk of others towards you. So always sit in an arm's length, at minimum arm's length gap with the patient. You should not touch patient without their permission or unnecessarily. Do not pose a gesture or body language that can be interpreted as intimidating for patients, because that can be a trigger for unwanted behavior. That's why in psychiatric setup we have 2 doors in every single setting, so that you can escape if you are at risk, and patient can also escape if they feel themselves are at risk. Okay? To start the interview, so of course make patients comfortable, make sure that you are free of interruption, explain the privacy, make sure the arrangement is comfortable for both of you. If you need to take notes, of course at some point you need to take notes, because things can get overwhelming, so that you need to keep track of what's happening. So explain to patient, because for example patient have suspicious idea, having you as somebody stranger come and ask all sort of questions, and you discuss with yourself about what to ask next, and you have chattings in the background, and then you write notes, so that can be a trigger for patients who have a pre-existing paranoid ideation or delusion. And make sure safety, I mentioned about this before. You will explore more about this in emergency psychiatry class at some point during year 5. Now, when we talk about how, this is some of the concept. One of the homeworks that I give to you is about listening to a demonstration of clerking and identifying the styles of interviewing that you can learn from. So among example of information gathering skills that are useful to use in psychiatry is one, using a mixture of open-ended and closed-ended. So instead of going straight to makcik ada rasa murung tak ke belakangan ni, so you may need to start with something that is more open. Boleh makcik ceritakan bagaimana perasaan makcik kebelakangan ini, perasaan puan kebelakangan ini. So that's open-ended. But of course, there are times where you need close-ended, especially when you want to get something that is that requires precision. For example, duration. So you may start asking about the symptoms, but when it comes to duration, patient, you have to be specific. Can you tell me exactly when did you start feeling this way? So that's close ended. Ataupun when you want to highlight a few issues. For example, you've understood that patient had hopelessness, you want to know about suicidal ideation, so you have to be specific. You ask about suicidal ideation in a very close-ended way. Ada atau tidak perasaan ini bunuh diri? So that's close-ended. So of course, there is no right and wrong, but you have to. It's a skill that you have to master. Generally speaking, the correct way is start with open-ended, narrow it down with closed-ended. So that should always be the approach. It's almost like macam tarik tali punya situation. Ada masa lepas, ada masa tarik, ada masa lepas, ada masa tarik. So that's a good history taking. And of course, listening skill. The problem with medical students, whenever they plug patient, what they have in mind is apa pula tanya lepas ni, apa pula tanya lepas ni, apa pula tanya lepas ni. So end up what happen is you fail to listen to patient's clues. And for example, patient might not give you a direct point on the question, or you ask about sleep, they say no, I don't have sleep problem. But in between of his or her chatting about other topic, he might throw 1 or 2 points with regards to doing things at night, for example, which basically indicates that patient hasn't been sleeping at night. So if you fail to pick up this clue, you will fail to get the correct information. So somebody who's listening well would say something like, tadi puan kata puan tidur dengan okey, tetapi bila saya tanya tentang apa yang berlaku 2-3 hari ini, puan cerita malam-malam banyak buat kerja, memasak, emas rumah dan sebagainya. So betul tak kalau saya cakap kebelakangan ni agak kurang tidur sebab banyak buat kerja? So this is the example where you do a lot of things. You do open-ended, close-ended. You do listen to patient, and you notice at verbal cues that patient's giving. You check with the patient. You encourage precision. So this is the skill that you need to master. So do not go macam robot, like tidur macam mana, makan macam mana, tenaga macam mana, sexual macam mana. Ada rasa nak bunuh diri, ada rasa nak bunuh orang, ada rasa nak bunuh binatang, ada rasa macam nak cederakan orang lain. So that's really robotic. So we don't want you to do that. Alright. And of course, another skill that you have to master is how to control the interview, but at the same time, do not get to the stage where you become an interrogator. So we don't want you to be a policeman. Pakcik kenapa dah sini? Baik pakcik cerita. Kenapa pakcik masuk sini? Pakcik kata tak ada buat apa-apa, tapi kenapa polis yang datang? So that is unlike. That is very unlike doctor's approach. So you have to be aware. Okay, so look at this. Get to understand the concept behind it, and when you see patient or when you hear clerking from the demonstration videos that we give to you, notice some of this. Okay. So starting the interview, of course, like any other parts of medicine, sama je. Kita tak start dengan balas pantun atau baca ayat-ayat daripada surah Al-Baqarah. Kita go welcome. Kita go straight to the business. Welcome patient by his or her name. Ask them what they prefer to be called. Introduce yourself. Explain why you're there. Explain what is the purpose of the interview. Make sure that what you going to do is confidential. So start with something like, boleh saya ambil sedikit masa untuk interview puan? Boleh saya boleh puan perkenalkan diri? Puan lebih selesa jika saya panggil ataupun saya panggil puan dengan nama apa? Puan, kalau puan okey, saya continue dengan puan. Saya such and such, pelajar tahun 4 perubatan. So hari ini saya nak minta sedikit masa daripada puan untuk menempuh bual. Tujuan untuk berbual ni adalah untuk saya belajar bagaimana bertanya soalan dengan pesakit. So ia bukan tujuan untuk merawat dan sebagainya. Saya yang sebenarnya nak belajar. Jika puan okey, semua yang kita akan tanyakan atau yang saya akan tanyakan ni, kita berbualkan ni adalah sulit dan saya tak akan kongsi dengan siapa-siapa yang tidak ada kaitan dengan urusan hari ini. Jika puan okey, boleh kita mulakan. So that is something yang should be standard. That's of course an example. You can do your version, but it should encompass this aspect. Okay, and other parts, of course, explaining that you will take notes, explaining that you have limited time, you might interrupt. So these are the things that you will pick up here and there once you see more patients, especially in year 5. We talk about being using open-ended. We talk about eye contact, understanding about verbal cues and everything. So that should start from the very beginning. Start with understanding chief complaint, and then you carry on with further question based on what patient have started to share with you from the beginning. So it is almost like a funnel plot, a funnel. Funnelnya corong, faham kan? Corong. So maksudnya dia start besar, dia kecil, sampai akhirnya dia ada mouth end of it. And so interview clerking macam tu. So boleh cerita kenapa puan dapatkan rawatan di klinik psychiatry ni? So start apa? Oh, saya stres, saya dah lama dah stres. Okay, boleh puan ceritakan lebih lanjut apa yang puan alami bila puan cerita ataupun cakap yang puan dalam keadaan stres. That's open-ended. So dia pun cakap, tiba-tiba dia kata murung. So now you know that you can start narrowing down into mood disorder in specific depression. Then you can start using some close-ended question. Boleh puan ceritakan yang puan cakap murung tadi tu dah berapa lama dalam keadaan macam tu, cuba close-ended. And then you start with supporting questions. So other features of depression will be included in the subsequent questions. So you start open, you narrow it down until towards the end you can almost cover at least one provisional diagnosis and having 3 differential diagnoses in mind. So that's your target in psychiatric clerking. So this is the example. When we talk about morbid disorder, we'll be talking about this in greater details. And throughout the interview, continue doing this. Clear questions, a mixture of open-ended, close-ended. Make sure that you follow through patient's thought. Do not interrupt patient unnecessarily. Don't carried away by patient's irrelevant thought if there is any. So this is something that you need to learn through while you do session. So teaching about this is almost macam driving school. So I cannot make you a good driver unless you've started to hold the wheel, hold the steering on your own. So, but the idea should be there. So macam kelas mandi kena ada teori dulu kan. So this is where we need to this is what we need to cover during this topic. The orders or the content and the structure of the other psychiatric clerking is as what you see here. So with presenting complaint, complete with HOPI, continue with past psychiatry, past medical, family history, personal, pre-morbid. So it's pretty much the same except that we put some emphasis here and there depending on the diagnosis. And in some cases, you might not come across such structure. Contohnya dalam physical history, you don't really bother about pre-morbid personality. In geriatric cases, you don't go through developmental history. So it's slightly different in psychiatry, where basically I must say every single thing in patient's life matter. But of course, you do not have 3 days with the patient. You have roughly half an hour to 1 hour with the patient. So you have to tailor your diagnosis. You have to tailor your history accordingly. course, in presenting complaint, what we want to see is this. So we want to know how patient end up in the hospital, whether patients voluntary or involuntary, what's their main problem, at least get at least 2 or 3 symptoms that will reflect your diagnosis. So if patient have 10 presenting complaints, you have to pick at the end when you present the case 2 or 3 that are relevant to your presenting complaint, your diagnosis. Presenting complaint does not need to be things that patients say first. Okay, patient may say that they come to the hospital because they feel stressful, but towards the end of the HOPI, if you find out that the actual problem is actually paranoid delusion, then you have to include delusion and suspicious belief as presenting complaint rather than stress. Okay, so we'll talk about this later during case presentation, but I just want to highlight the idea about what to include in the presenting complaint. And in history of presenting complaint, these are the things that we want. Essentially, we want symptoms, we want context of the symptom, we want duration, we want evidence that it impairs patient function, and we want enough information to exclude other differential. So why do you need this? We'll talk about it during the discussion. But have a thought about why I put all of this in the HOPI. Okay. So the good HOPI is when you are able to come up with something like this, which is a time frame. You can translate the story into you can visualize the history into something like this, a time frame or timeline. We'll discuss about this later to understand why does it matter, but just have an idea about the importance of this. Later on, when you do your homework, I want you to translate information that you get from the videos into a timeline. Okay, so I want you to have a picture, or bukan apa kita panggil ni, write it somewhere, draw it somewhere. What is the event of stressor? What is the symptom? What is the evidence that patient has disturbed function? And how things progress from the beginning of the problem until the time of presentation. Okay, so have a look at that, and then you will understand why. Of course, past medical history, past psychiatric history are things that we also include as part of the history, because most of psychiatric problems are longitudinal in nature, chronic in nature. So we need to understand what's going on behind the scene, okay, the background history of the background stories of current presentation. So for example, if you have somebody presented with depression, the fact that 10 years ago patient has had manic symptom really matters, because it differentiates between major depressive disorder and bipolar disorder. So so you have to understand why all of these are relevant. Okay, so of course family history you translate into genogram like any other part that you've done in medicine. In personal history, basically you go through chronologically what happened in the patient's life. There are things that you need to highlight. You learn to pick up what are the things that is important once you get to know all relevant diagnosis in psychiatry. For example, in depression, for example, so things that happen during childhood, relationship with parents are relevant, so you want to know this. For childhood related disorder, developmental history is important, so you would know what to expect in psychiatry, what to expect in certain part of history. Once you know once you get to know the once you get to know the content of the history. Okay. And of course, social history more relevant to what's happening now, where, how patients doing currently. Can you just go through this? I don't have to specifically go through one by one. Forensic, of course, where it's relevant. And another important thing that you don't normally talk about in psychiatry is pre-morbid personality. The idea of asking about pre-morbid personality. Pre-morbid means what's patients like, right? What's patient like before, right? What's patients like before patients become ill? Who they are as a person before they're ill. There are two reasons why you want to know pre-morbid personality. One, we want to know whether patient has, if patient has underlying personality disorder on top of current examination. Patient may have something like depression with underlying borderline personality disorder. So basically two diagnoses. Anxious personality disorder for somebody who later on developed panic disorder, for example. So that's one reason. Second reason is we want to know the strength and weakness of this patient in order to tailor it into the management. So, for example, patient pre-morbidly is somebody who's very poor in coping style, do not know how to cope with stress, very bad in terms of social support, the way they interact with others. Therefore, you will include this in your management. So you want to include things like social skills training, coping skills management, stress management, and so on. Okay, so you have to know this. Okay, so that's in essence the content and how it's done. So one of the last few slides we'll talk about how to deal with problematic patient. So problems can occur in various ways. It may be your problem, you're too anxious, you don't know what to ask, you don't ask it correctly, but we'll talk about it. But the second part is maybe patients factor. For example, you may have patients who are anxious, patients who are uncooperative, patients who are dominating the interview, patients who are very quiet, or the other extreme, over talkative, or very disturbing to the point where you're not able to interact with the patient. So so these are the skills that you have to learn. So I will not go through this in details because we will discuss this in this discussion. But some of the examples are there for you to have an idea about what need to be done. But the concept is to be adaptable and flexible in the given situation. For example, somebody who are really anxious, so you may end up, instead of jumping straight to the clerking, you may need to stop patient and get patient to do some deep breathing, for example. So this is something that normally happen in real life. Saya nampak sangat anxious kan, sangat takut, itu panggil panic. So saya rasa why don't, instead of saya terus tanya soalan, kita sama-sama buat something yang kita panggil deep breathing. So kita bernafas sama-sama, tarik nafas ikut saya, tahan dengan hembus, kita buat ni 2-3 kali. So basically ini yang puan perlukan sekarang, so that puan lebih relax. Okay, so after that then only you start, or it may be something along the line of saya nampak puan agak anxious nak bercerita. Saya tahu mungkin agak janggal nak bercakap dengan orang asing macam saya, kita tak pernah jumpa, tapi the idea is untuk saya faham keadaan puan. So semua orang pun yang duduk dalam posisi pun mungkin akan rasa perasaan yang sama. So it is normal. Saya pun mungkin akan rasa takut juga kalau ada orang tanya saya soalan macam-macam. Tapi kita cuba untuk berbuat sikit demi sikit. Apa yang puan rasa okey untuk cakap, puan cakap. Kalau tak okey, kita stop. So things like that sebenarnya adalah benda you have to learn. Otherwise you will not be able untuk get to the patient. Dia nak tanya pasal anxiety symptom, you nak tanya panic disorder, tahu panic ada 4 symptoms, GAD ada 4 symptom. Tapi kalau patient suffocating with anxiety, choking with emotion, tak kisahlah patient ada 80 symptom sekalipun, you will not be able to get it. So you have to understand this. Alright, and then ending the interview, remind that interview is almost end. Ask the patient if there's anything that you miss. Get the patient to ask questions, everything. And of course, your response should be professional. Jangan, puan tak ada apa ni, insyaAllah. So baliklah ni, what apa? Padahal you don't know anything about what's going on. So do not respond unprofessionally. Thank the patient. Do not forget. And if you are in a treatment setting, you discuss about what's going to happen. So in exam, for long case, in year 5, end of block, final pro, you will not be interviewing patient in front of examiners or in front of psychiatrists. So we won't be judging how you ask the question. We only want to listen to your presentation. But in short case, in between posting, within the posting, you will have short case assessment, whereby you will be assessed in front of the psychiatrist, and we will see. We want to hear what you ask and how you ask things. So in this situation, display proper, appropriate history taking skills are the key in handling the exam situation. So start by introducing yourself, ensure confidentiality, explain the time allocated, get to know patient background, understand patient's presenting complaint, and have a focused HOPI in order to get diagnosis and differential diagnosis, and get to know things that you can exclude from the HOPI, and then end the interview. So all of this should be done within 15 minutes. Okay, so we are at the end of the interview. Cakap. So these are the key messages. So have a focus history, because focus history taking will ensure proper diagnosis and management. Good interview techniques will feel smooth history taking. In between the interview techniques, what you also need, more importantly, is the ability to show empathy and have a good listening skills, because they are therapeutic for patients. And more importantly is your ability to show respect towards your patients, to know that they are human beings, not diseased organ or subject for your posting. So that's in essence what we need to learn today about interview techniques and history taking for psychiatry. So homework guys, siapa yang dah tertidur tu bangun. So sekarang we need to talk about homework. So you need to watch the following video on psychiatric clerking demonstration. So once you watch the video, if you find it difficult to understand the accent or the slang, use the subtitle. And then based on the interview, I want you to do 2 things. Number 1 is prepare a timeline for the HOPI, as if you are the one that clerking the patient, because I want you to present it back. I will choose random students to present on the day. I will pick 1 or 2 from the audience during the session to present your history. I want you to show your time frame, and second is I want you to identify 1, 2, 3, 4, whatever amount that you see, the relevant interview techniques with examples as displayed by the demonstrated in the video. So that's all. Thank you so much for listening. I hope you have not gone asleep halfway through. So that's in essence what you need to learn. So we'll see you again in the next video, inshallah. Assalamualaikum warahmatullahi wabarakatuh. And have a great good day.